Hello, I'm Dr. Michael Cook. And this is Controlling Astigmatism and Nearsightedness and Developing Youth. This is about how we make a kid not get worse anymore. Stop them from getting more and more nearsighted, needing stronger and stronger glasses. Click. So, myopia ain't getting no better. Kids are getting more and more myopic at earlier and earlier ages, and it's happening more and more commonly. Click. So in the United States in 1971, 25% of American adults are nearsighted. Now in 2000, 42% of Americans are nearsighted. Click. Taiwan's another great example. In '83, you can see as the kids got older, 7 years old, 12 years old, 15 years old, they got more and more nearsighted. 64% of Taiwanese children at 15 are nearsighted, but that was in '83. In 2000, we get more and more commonly, 81% of 15-year-olds in Taiwan are nearsighted. So the point is, it's happening more and more often, which kind of argues that it's not just genetic. There's other factors that are causing that. Click. A lot of people think nearsightedness is solely associated with reading, and that may or may not be true, but one thing that would argue against that is there are kids on the island nation of Vanuatu, spend 8 hours a day in school, 1.3% of them are myopic. So why that is kind of confusing, and I don't have a lot of intelligent things to say about that, but it kind of confounds. It's just that the point is not everything is known. Click. So who cares? People are have nearsightedness. It's not, a lot of people don't associate that with like vision loss or functional loss, but click. Any amount of nearsightedness is actually dangerous. The more nearsighted you are, the more prone you are to actually retinal detachment, but also glaucoma and early cataracts, as well as myopic degeneration, which is the 7th leading cause of legal blindness in this country. Click. Yes, and obviously also the more myopic your kid is, the more likely they're going to need glasses for more and more activities, the more dependent they are, and later on the more likely they'll seek out surgery. And the more nearsighted you are, the riskier LASIK or other refractive surgeries are. Click. So what can we do about it? So the first thing, the classic thing that optometry's been talking about for 70 years would be visual hygiene, which is basically about being as efficient as possible when we read, when we do near tasks. The first thing would be obey the 20-20-20 rule. Every 20 minutes, have the kid look 20 feet away, at least for 20 seconds. Okay, just basically frequent breaks when we're doing computer work, near work, working on iPads, iPhones, and homework. Click. Another thing, for every hour a child spends outside per week, they're 2% less likely to become nearsighted. And that's actually even controlled for reading. So kids who read the same amount play on the computer the same amount, but if kid A is outside more than kid B, then kid A is less likely to become nearsighted. We actually also have data that shows, though, that once the kid does become nearsighted, outside time doesn't actually matter anymore. The progression is the same, but it does prevent it from starting in the first place. Click. So another thing to think about why kids tend to progress, get way more nearsighted, and adults tend to be stable is if you look at generally how adults use their vision, click, they usually have much better working distances, much more natural type conditions or uses of their vision, click, than a kid does. Here we see kids looking at books 10 inches away, which is really, really common. We'll see kids with their heads on one side so that in this case, the right eye's way farther away from the material than the left. Often that's been associated with an uneven prescription. So you have one kid that's one eye's way the heck more nearsighted than the other. Often you'll see that this posture is very, very common with those kids. Click. So since the 50s, we've always talked about the best posture for a kid. So basically, when the kid is reading, they actually had specialized desks back in the 50s, which they don't do anymore, where the kid's feet would be flat on the floor. When they're seated, the thighs would be parallel with the ground. Their back is straight. They're up and the reading material, if they bend their elbows like that, reading material is about that distance, definitely no closer. It'd be farther, but this would be the most efficient. And hopefully the less stressful, possibly inducing less myopia or nearsightedness. Click. And so that's just more showing that, again, with the kid with the turned head, often will have worse acuity and more nearsightedness with the eye that's closer to the material. Click. Take that out. So this is all what we want. This would be good. See, kids usually have the slanted desk back in the day, not so much anymore. Click. So another thing that we like is good equal lighting when the kid works. So, we do like lighting hopefully from two sides, or at least centrally, not just one coming from the side. And we do like incandescent lighting better than fluorescent lighting. It has a more even spectrum of light, which just tends to be more comfortable. Click. So other things we can do about it once the kid becomes nearsighted is fitting the kid into actually bifocal or multifocal soft contact lenses. That's actually been associated with a reduction in progression by about 40%. Usually we just think of them being used for people older people when they actually need a bifocal, but you give a kid one, give the kid a little help for reading, maybe that's why, but we do know the correlation is there's a 40% reduction overall between a kid who wears a multifocal soft contact versus a kid who wears just standard distance-only contacts or glasses. Click. Atropine eye drops have actually been studied for 90 years. There's studies from 90 years ago and all in between that show that actually 1% atropine slows down myopia 90%. It is extremely effective. It's probably the single most effective thing there is. However, click, it's associated with, oh shoot, I went too far. Go back. It's associated with fully dilated pupils. 1 drop of atropine will actually dilate your pupils for 10 to 14 days and make reading absolutely impossible, which those two side effects kind of take 1% atropine off the table for the vast majority of patients. Kids who do it will have to wear the transition lenses that get dark when you go outside, and they'll need a full super duper strong bifocal. In the aforementioned countries like Taiwan and Singapore, where it's just horribly epidemic nearsightedness, 90%, 6-year-olds wildly severely nearsighted, that they actually commonly treat that way because that's actually getting very pathological very young. So, but most people don't really like atropine. Makes the sun super bright. They got to cover themselves with umbrellas. Okay, move on. So, but what we do offer is, instead of 1%, 0.01% atropine, which will have a small effect on reading and dilation, but generally the child themselves don't notice that. The kid's still 20/20 up close, doesn't complain about glare at all, and that will reduce progression 55%, which is still quite effective with way the heck less side effects. So that is something we do offer, but it hasn't been fully studied about exactly what it's going to do to a kid's reading. Yes, the kid's 20/20, but is the kid going to read 20/20 for long periods? Is he or she going to be able to do it effortlessly? That hasn't been studied at all. So if we do choose this method, I like to see the kid do a full evaluation of their focusing mechanism before the drop, and then 2 weeks after the drop, and then 6 months after we start the drop, to make sure they're not having more subtle symptoms or more subtle difficulties with reading. So the kid would be seen and then on every couple of years, or twice a year. Click. We also have gentle vision shaping, or orthokeratology, if you want to look it up on the interwebs. That's where instead of contacts and instead of glasses, I'll actually design a retainer, which will look like a little hard contact lens that instead of wearing during the day, the kid will put on just before bed. So the kid puts it on before bed, sleeps in the retainer, wakes up, removes the retainer, and then needs no correction whatsoever. for the remainder of the day. So during all waking hours, the kid doesn't need any help at all. 20/20 vision, very sharp. And that will tend to reduce progression about 80–90% for kids who choose to correct their myopia in that way. Click. And it's really cool. Click. And this is a quick demonstration. So you can see this is just demonstrating that with the nearsighted eye, light is focused in front of the retina, not on the retina, and that'll blur it. So you put a lens on it, or a lens in front of the eye, and it focuses on the back of the eye, on the retina. This is showing what LASIK does. LASIK will permanently alter the cornea, and that will also focus light on the back of the retina. Another method, this is what I'm talking about, the gentle vision shaping. Put a retainer on the eye while the kid sleeps. Overnight, it gently, very subtly reshapes the cornea. Remove the retainer, and for the rest of the day, completely temporary, completely reversible, but for the day, 20/20 vision. Super sharp and relatively straightforward. Are there any questions? Remember, there are no stupid questions, just stupid people. Yes, you with the dumb question.